Welcome back to another episode of Talk Your Abs Off. Today's episode is really special. I have someone local to me that I get to chat with today. She is a doctor of physical therapy. Today we get to chat with Dr. Cheryl Mitchell. Cheryl brings more than 12 years of physical therapy experience in outpatient orthopedics, hypermobility, post-concussion care, and she founded Inspirational Physical Therapy and Consulting in 2022 with the mission of providing evidence-based, one-on-one care to her clients and spreading awareness and knowledge about Ehlers-Danlos syndrome and orthopedics. She focuses on integrating research with individual patient needs and goals to provide high-quality care and achieve results, which I love. We are all about evidence and science-based here. So Cheryl, welcome to the podcast. I'm so glad to have you.
Thank you so much for having me. This is such a pleasure to be here and to meet you, and hopefully to be able to help people in this area together.
100%. This is a topic that I love and that I'm excited to dive more into. This is actually the niche that I plan to kind of take some of my social media, my podcast. So this is a really great segue into that. So today we're talking about hypermobility and Ehlers-Danlos syndrome, which we will call EDS moving forward. So if you hear EDS, we're referring to Ehlers-Danlos. So Cheryl, first I want to start with a little fact or myth game. I'm going to give you 3 statements and I want you to tell me if they are true or false. And I would say maybe give me like a 1-sentence answer as to why it is what it is, if you can do that for me.
Sure.
Okay, perfect. So the first statement is hypermobility automatically means that you are good at yoga and or gymnastics.
First of all, that's an awesome statement. False. Hypermobility definitely has flexible joints. So a lot of those clients find themselves doing things like yoga or gymnastics because they're flexible, but not all EDS has hypermobility part of it. And also you're not automatically going to be good at those things just because your joints are a little bit more flexible than somebody else's.
Ooh, I love it. Answer 1, knocked it out of the park. Question 2, hypermobile clients just need to stretch more.
Oh my, please do not. You say they need to stretch more. That is definitely false. So stretching when you're already hypermobile can actually be more harmful to the body than good. Really, the key with hypermobility is stabilization and strengthening. So when a joint has more mobility or it can move more than a normal joint, then it's inherently more unstable than a normal joint. Now, some people are hypermobile and they go through their whole life pain-free, full function, no problem, and they do great. Other people start to have pain at a very early age because of this hypermobility. But for the majority of my patients, you don't want to just stretch as a general rule. That being said, if you have a specific muscle that is specifically tight, then you can stretch that muscle carefully. A lot of times my patients respond better to like a trigger point release or like a trigger point ball to make the muscle kind of reflexively relax as opposed to trying to stretch, because stretching doesn't always help the way that you think it's going to.
I like that. I like the trigger point release. And I want to come back to that because I've been seeing, because now, my algorithm is full of hypermobile personal trainers who are talking about it. And so someone did bring up using like a lacrosse ball or something to loosen up the traps as opposed to trying to stretch it. So I love that topic. I want to come back to it. Third statement is that strength training is dangerous for hypermobile clients.
Oh my gosh, please false. Strength training is so good for the hypermobile. So I guess I kind of already said this, but kind of circling back, when the joint is inherently unstable because it's more mobile, building up that strength and stability is really, really important because that's what's going to stabilize that joint. With hypermobility, the body doesn't produce collagen correctly, and it's due to genetics. So it's something that the person is doing wrong, or they're not doing the right nutrition, or they did this one injury this one time. Like, it's nothing that is their fault. It's just the way that their DNA is that is not producing collagen correctly. So the ligaments, which attach bone to bone, are not doing their job. And a lot of our connective tissue throughout our body, that's all collagen as well. So like your labrum, which is kind of that cup that goes around your shoulder and in your knee, it's not as stable as somebody else maybe down the street. So building the strength and stability specifically of kind of your key postural muscles and like your key stabilization muscles, like your rotator cuff, that is vital to the hypermobile client.
I love it. You knocked all 3 out of the park. Thank you so much for answering those questions. I think that there might be just some confusion or questions around hypermobility, and I think that kind of answers everything in a sweet little nutshell to kind of kick us off. So, um,
Perfect.
you already kind of defined hypermobility, and we also mentioned Ehlers-Danlos syndrome. So, I want to talk about EDS, this Ehlers-Danlos, and because I know that there are 13 types of EDS. There's more. I am just learning this like over the past year that there's so many different kinds. I just thought, oh, hypermobility, EDS, that's one type. And there's also classical EDS, which is what I also see a lot with my clients. So can you just explain Ehlers-Danlos just a little bit more in depth and how it presents itself in patients or clients?
Yes, of course. I'm happy to. So, first of all, just kind of at the root thing of EDS, it is genetic. So, it is passed down but within your family. So, one of the reasons why you see it diagnosed so frequently now versus before is now that we know that it exists more than we thought, we're looking for it more. And then when one family member, so say mom, gets diagnosed, well, now we look at grandma and we say, oh, that's why grandma was walking on her ankles instead of her feet. And then we look at cousin, and then we look at kid, and now we have 5 people diagnosed within probably a 6 month to a year period. So EDS overall, as Abby already said, it has 13 different subtypes. So the most kind of famous, infamous maybe subtypes are classic, which is of course classic EDS. So that's kind of your classic symptoms where you have some hypermobility, you have some other joint issues, you have some GI issues. And you can actually go to the EDS Society website and you can look up the different kind of classifications for that as well. The most common one is hypermobile EDS. So this is the one you're going to hear the most about. This is the only one of the 13 subtypes that we don't currently have the exact genetic variant that they can diagnose through genetic testing. So
Really?
whereas the
Wow.
other
Creepy.
12, yeah, the other 12 subtypes, they know exactly where to look on genetic testing. So that is how they are diagnosed. With HEDS, and one of the reasons why it's a little bit more controversial, so hypermobile EDS is HEDS, is we don't know that a little bit. So it's diagnosed via clinical exam and history of the client, and then family member history. So there's a couple of key things that the doctors might look for in addition to hypermobility, which is assessed using the Brighton scale or the Baton scale. The Baton scale being kind of the more famous of the two, where they look at your hypermobility of your thumb to your forearm, your pinky going back, your elbows hyperextending, your knees hyperextending, and then hands flat on the floor, leaning forward. So if you hit those criterias and you score it out of 9 points, and you might get like a 7 out of 9 or a 2 out of 9. And then they ask you a bunch of other questions as well. The other kind of famous one, or infamous definitely in this case, is vascular EDS. Vascular EDS is the most infamous of all the EDSs, and the reason why they do genetic testing if they even think you have HEDS is because the vascular has a lot more potential for like young heart attacks and other issues, where those are the ones that tend to have not as long of a quality of life and not as well of a quality of life. But certainly with the other subtypes, especially if you're diagnosed early, so you can avoid dangerous activities that are more likely to cause harm to your actual joints because you're hypermobile, you can still live a long and very full life, especially with the right treatment and strengthening.
Wow, that is so interesting. I had no idea that it was that closely related to like the vascular piece of it as well. That is a new piece of information for me, and that's super helpful. And I know some of the other types, it really affects like can affect your organs, it can affect your eyes, it can affect so many different things depending on
Dental.
which one. Yeah, yeah. It's
Yeah.
so interesting. When I started to dive into it, I was blown away by really how deep and how intense it kind of goes. So that's yeah, very interesting. Also, I need to ask. So we're on video. So if you can watch it on YouTube if you want to see. I have a question. Are you hypermobile yourself?
I'm actually not. I
Okay.
call myself the slightly hypermobile mobile PT because I'm a mobile physical therapist. I go to my clients, and I just am like slightly hypermobile. So like
Okay.
I can't,
I
I'm
saw
not
you do
quite
the thumb
there.
party trick, which
I'm
I
not quite here,
yep.
but I tend to be more on the flexible side. So I get that question a lot.
Okay, I was curious because I there's an episode where I talked to one of my clients who's hypermobile, and she showed everyone her party trick of her thumb to her forearm, and I saw you do it, and I was like, oh my gosh, do we have one in our midst?
Yeah. Although I will say this one's cheating because I broke this one, so it doesn't go back, but wouldn't have wouldn't have
Oh my
before
gosh.
either.
I love that. So, some of the hypermobile signs that I start to notice in clients are when I work with hypermobile clients are extended range of motion. So, like you said, like the extension of the elbow, maybe the knees go back, the party tricks that you showed me, maybe hypermobility of the neck as well. What are the first things that you notice as a physical therapist when someone comes to you and they are hypermobile?
I would say the same.
Okay.
Because I look at how people walk and move, oftentimes before they even approach me, I'm already looking at how they're walking and going, I think that person's hypermobile. But yeah, it's definitely the elbows are the most obvious, and then the knees hyperextending are the most obvious. But just kind of overall how they're walking, and I want to explain that a little bit more. I don't want everyone to think that they're walking weird to the normal person, but I'm a physical therapist, so I watch how everyone walks. So I'm not like standing there like, oh, okay, yeah, I kind of am analyzing everyone who walks by. Um, so beware if you see me out on the street. Um, but because EDS is genetic, when you learn how to walk when you're a baby and then you're a toddler and you're learning how to crawl and walk and run, you already are hypermobile whether you know it or not. So a lot of my patients have similar gait deviations. So maybe they're extra flat-footed and so they're not getting as good of a push off with their walking, or maybe they have some different compensations where they're trying to prevent their knee from hyperextending while they're walking. So there's other kind of telltale signs that I can just tell by overall movement patterns that also kind of clue me in.
Yeah, that 100% makes sense. And when we're looking at someone who's hypermobile and they're coming to your office, or if I'm working with someone who I know is hypermobile, also hoping that they've had experience with a physical therapist and are seeing one at the same time as doing their strength training with me, stabilization is such a big thing when it comes to hypermobility. You mentioned it earlier. It's the first thing that I look at and start working on with someone who tells me that they're hypermobile. And why do hypermobile clients often need stabilization and strength training over that stretching?
So it's because you learn how to move when you're hypermobile and you have all these compensations from when you originally learned how to move and reach and walk. Those tend to go towards the bigger muscle groups. So we tend to see a lot of upper traps overcompensating. So when you reach your arm up and overhead, a normal person who hasn't had a shoulder injury, the shoulder blade actually goes downward as the arm comes up. And that's the normal scapulohumeral rhythm, or how that shoulder blade communicates with the arm. In my hypermobile people, I tend to see compensations with upper trap hiking. So like they elevate their whole shoulder. And I also see a lot of protraction. So they tend to kind of do this with their arm. So by stabilizing the shoulder and decreasing how much they're using the upper trap, so you strengthen your rotator cuff, you strengthen your neck muscles, you strengthen your mid trap and your rhomboid. So I know I just threw off a lot. If you watch the video, I am pointing to them, but your mid trap and rhomboid are in between your shoulder blades. So by strengthening those, you're taking the pressure off of the overused muscles, which are usually really tight and painful because they're doing their job plus the job of a bunch of stabilizers. And then you're putting it back on the muscles that are supposed to be stabilizing you and are supposed to allow you to move outside your actual body.
Okay, that makes sense. And so what I'm hearing is if someone's hypermobile and they haven't worked with anyone, they haven't seen a physical therapist, it is possible to retrain their body to move properly.
Yes, it is usually slow and steady progress. But yes, I typically start with kind of postural stabilization, cervical or neck stabilization, and then kind of mid back or thoracic stabilization, and then lower back core stabilization. And then we start to move out into the arms and the legs and do more of that. But once we kind of get the core stabilized, then the core can stabilize the body while you move your arms outside.
Amazing. Okay, so what I'm hearing and what I'm going to tell all the hypermobile people listening is go see a physical therapist, and if you are not already, now's the time. Start working on all that.
Go see a physical therapist who knows how to treat hypermobility.
Also that, yes, good clarification. I love it. So I think there are some differences with hypermobile clients than with people who don't have hypermobility. Can you tell me a little bit about how hypermobile clients experience and maybe describe discomfort differently? So let's say they're exercising. Do they feel that discomfort or soreness differently than someone who's not hypermobile?
That's an interesting question. So My subset of hypermobile, obviously, they're coming to PT for a reason. So I usually see the people who have pain with their joints, as opposed to just what used to be called benign hypermobility syndrome, which is just you're hypermobile, but not necessarily painful hypermobile. So a lot of my patients are in chronic pain. And when you're in chronic pain, your whole perception of pain changes a little bit. It becomes a little bit more, and I don't want anyone to take this wrong, but it becomes tied into kind of psychological and emotional in addition to just true pain. So whether you're hypermobile or not hypermobile, like if you burn your hand on the stove, ow, that's hot, you remove your hand and then you run cold water and the pain goes away. But when it's chronic pain that's constantly coming from your shoulder or from your joints, your brain tries to kind of like turn off that sensor, but it's not always effective. So then that pain can get overridden by other stimuli and it gets a little bit more complicated. And because it can also be very frustrating, that's where the kind of psychological, emotional components come in. So that's not saying that, there's psychological or emotional issues. I'm saying the pain itself becomes psychological and emotional. So again, not that anyone's doing anything wrong, anything like that. It's just, that's just kind of the nature of the pain. I would say also a lot of my patients are very used to pain. So, if Joe down the street subluxes his shoulder and his shoulder is no longer in the joint, he's going to probably go to the ER and have it put back in. My hypermobile patients are like, oh, my shoulder's out. It's been out for a couple weeks. And then like, I'll put it back in for them. I'm like, oh, wow, that feels a lot better. Like it's been out for weeks, sometimes years. And the joint's just not quite sitting right in the socket. And putting it back in makes a huge difference for them. But they're so used to pain that I don't think they have a really good scale of what other people would say would be a 10 out of 10 pain. Like most people would say that having a joint out of the socket would probably be pretty close to a 10 out of 10, but my hypermobile patients walk around like that all the time.
Yeah, I think that makes a lot of sense. I do have a couple people who will take my group exercise classes, and I'll ask how they're feeling before class, and they say, oh, just it's just another day, feeling the same.
Mhm.
And it's but they're still choosing to participate in group exercise classes and do what their body can do, and we make modifications as we need to, which I think is one of the most important things. But I do think it is interesting to, especially as a personal trainer, to recognize those different pain scales, or even just like the rate of perceived exertion when we're working out with someone on a scale of 1 to 10. How are they feeling? It might look a little bit different than someone who's not hypermobile.
I would definitely agree. And I love that you're modifying things for them. And I also love that they're actively trying to get out there and exercise, because really that's the best thing for hypermobility and EDS is exercising at the level that they are. I just always tell my clients, you have to meet your body where it is. So,
Yeah.
you can't like go for a run along the beach, but we can definitely do some stabilization exercises that can get you to the point where maybe you can get back to the beach and go for a walk. And then eventually, depending on the person, go for that run. But it's not going to be a marathon today.
Right, absolutely. And I think now is a good time to talk about, like I said earlier in the episode, I'm seeing more personal trainers who are recognizing hypermobility in their clients, which I think is important because I do think that it's something that there's not a lot of experience in. Like it's not something that I learned about in college when I was going through my exercise science program. I'm kind of learning along with my clients as I go, which has been such a big blessing in my own career. But seeing other personal trainers who are maybe hypermobile themselves and discussing what different things can look like, how to work through things is great. And so, you did talk about that trigger point release, and I want to touch on that a little bit more. So if we're looking at if someone who's hypermobile is maybe taking a yoga class, and I will have hypermobile people who come to my yoga classes, and things just need to be adjusted a little bit differently to make sure that we're not overstretching or putting pressure on things like that. So let's talk about the trigger points and how that can benefit, either as opposed to or in tandem with stretching.
So with stretching, you're kind of only stretching the tightest part of the muscle or joint, and sometimes you can overstretch the tendon part, which has some collagen in it. And again, collagen is that thing that's not being produced correctly instead of the muscle belly. So a trigger point is basically the point of the muscle where it's kind of what it feels like is it's where the muscle is the tightest, but it's a place where you can push, where you actually can get the whole muscle to reflexively relax. So some doctors will do like trigger point injections. You can do trigger point with like your knuckle. You can buy a trigger point cane to apply pressure, and then you can use a lacrosse ball. So earlier you had mentioned using a trigger point ball on the upper trap. I don't know how easily you would be able to do that, but there is a Theracane that has like a little hook on it, and I have one, but I would have to step off camera to get it. But like I'd love to use lacrosse balls or a trigger point ball on the piriformis, which is the muscle kind of in the middle of the bum. That's a hip external rotator, but it also really stabilizes the lower back and the pelvis. And it's a pinpointed spot where a lot of my patients have a lot of pain. So that's a really easy one that they can put a ball against the wall. They can literally just kind of lean against it. So they're in a safe position. They're not trying to like do crazy things with a foam roller. And then they can get that to release for them.
That makes sense. I also think that that is really good, even for someone who's not hypermobile. To get
Yeah.
to that piriformis is so difficult. So, if anybody, even if you're not hypermobile, give it a try, because that sounds like it would be amazing. It's always hard to hit that piriformis. So, if someone, let's say that we have a hypermobile client patient who is exercising, how would recovery look different? Does their recovery days within the day or two after they exercise look different than someone who's not hypermobile?
Absolutely, it does. So, EDS is associated with a lot of different syndromes as well. So, we usually call the trifecta EDS, MCAS, which is mast cell activation syndrome, and POTS, which is postural orthostatic tachycardia syndrome. But also, it can be related to like a chronic fatigue and then post exertional malaise. So, post exertional malaise is kind of a really fancy medical word for when you do activity, whether it's working out with Abby or whether it's going for a really long walk around the block with your dog, you're more tired the next few days. It takes you longer to rebound. So kind of how you counter that with the EDS or the hypermobile population is that slow and steady. So I always tell my clients slow and steady wins the race. If you do too much too soon, then you can redline the system and put you back in bed for another week. Or if you just do a little bit too much, it can still take 2 to 3 days to recover. But if you do slow, steady progressions and listen to your body each day, then you can make really good progress.
I think you hit the nail on the head with the listening to your body part. I think that's one of the most important things, especially people with chronic conditions or hypermobility. It is so important to recognize how your body's feeling as you're exercising. And this is kind of a little bit of a tangent. So I listened to a podcast that it talked about hypermobility, MCAS, and POTS all being related. It was a very sciencey podcast. I did not fully understand. Can you give me like a short, like little explanation of how all three of those are kind of intertwined with each other? Because I do think that that's really common, and I have seen that with some of the people that I've worked with myself.
So I don't know if I can give you the link between it without being a little bit sciencey,
That's okay.
but I'm going to do my best here. So first of all, kind of definition wise, mast cell activation syndrome or MCAS. Mast cells are like your little cells that help you with allergens. And so it's like your histamine cells. There's a couple different things you can do with the mast cells that when they aren't working right, you can have too many mast cells, or you can have the same amount of mast cells, but they kick in too soon or too many. And that's what mast cell activation syndrome is that this population tends to have these mast cells that overreact to a stimuli. So in this patient population, if they do have MCAS, they tend to have more allergic reactions than usual. So that can be latex, that can be lots of food allergies, that can be medications. Overall, I would say that this population tends to metabolize medications and food differently than other populations. Where it really comes in is key is that medication aspect. So if Joe, again, poor Joe down my street here, I don't actually think I have one, but Joe down the street goes in and gets a cortisone injection, the doctor kind of knows how he's going to react to that. Yeah, there might be some contraindications. There might be some soreness or some redness in the area. Well, an EDS patient might go in and they might have a huge inflammation response of that area. They might have an allergic reaction to that. They might go in and they may not feel it at all. They may have zero benefit from it just because their body is going to metabolize it a little bit differently. So with POTS or postural orthostatic tachycardia syndrome, so that's a lot of words there. So basically orthostatic means if you go from like a laying position to a sitting position or a sitting position to a standing position, your blood pressure drops a little bit and then it's supposed to come right back up. You have this cute little baroreceptor in your heart that's supposed to signal that you're changing positions and then it changes the blood pressure in your body. Tachycardia means fast heart rate. So basically, in people with POTS, when they go to do that movement, instead of that drop in blood pressure and then immediately back up with the baroreceptor, their heart just starts going really crazy. And sometimes the blood pressure goes crazy too. And they're more likely to have an episode of what's called syncope or passing out. If they don't fully pass out, they may gray out or they might see spots. Kind of the genetic link there is the arteries and veins have collagen in them. So
Mm-hmm.
you can't get the blood flowing back up to the heart as well as maybe as somebody else because it's a little bit more elastic. And kind of the same with the GI symptoms, that the GI tract is a little bit more elastic. So things tend to get kind of stuck instead of getting forced through like it normally would. So kind of a counter to that is a lot of patients find a lot of help with like a compression stocking, because when you add a compression stocking, that helps with the blood flow back up to the heart. And now they're not getting that drop and then increased heart rate as much. Also, drinking lots of fluids, like lots of fluids. Just make sure that you're checking your electrolytes and you're not going too far the other direction, because sodium is also an issue with these patients. Typically, they need extra sodium and extra water, but check with your doctor, because if you aren't low on sodium and you do too much sodium, that's a big problem. So just make sure you're following up with your doctor for specific recommendations. But typically, like a lot of my patients like to do the liquid IVs or the LMNTs to get that extra sodium and electrolytes in addition to extra fluids.
Thank you so much for explaining all that. And honestly, you explained it perfectly. I was able to understand it way better than the last podcast that I listened to, which was it was way in depth. So I think this was a good kind of overture that really helped explain it in a way that that hopefully, if somebody has it, it's easier for them to understand. The link between the arteries in hypermobility and the POTS, it makes so much sense now. So I definitely understand that a little bit better. So thank you for that. I love that.
You're welcome.
I'm learning something today. I always love learning something on my own podcast. I think it's great. Now, going back to just the hypermobility piece of it, are there certain movements or activities that people should avoid, or would you say just approach differently?
So that's a hard question because there's such a big spectrum of what hypermobility is. So what might be unsafe for person A might be absolutely fine for person B. I don't know that there's any specific thing that I would say this is an absolute no-go. I would say that people with hypermobility are more prone to concussions and like post-concussion syndrome with prolonged factors, which is actually how I originally got into treating more EDS, was that dysautonomia overlap between post-concussion and EDS. So if anything, I would say avoid potential head trauma sports. So football, soccer, rugby, those types of activities. Be careful with like cheerleading. Be careful with anything that's going to push maybe too far. So like acrobatics, again, like you had in your truth or myth at the beginning, a lot of hypermobility people are like, oh, I'm flexible. This is a strength. I should go do that, which can be really good as long as you're using that strength and you're also staying strong.
Mhm.
But I would just be cautious with overstretching.
That makes sense. I think that's a really good point. Now, what would you say are some underrated tools or practices that can really help with joint stability or pain day to day with someone?
Working those postural muscles. Absolutely. So a lot of my patients, if they wake up in pain, they have certain exercises that they can do and activations that they can do that, again, takes the pressure off the joints that are painful. And then isometric exercises are really good for people with EDS too. So an isometric exercise is muscle activation without movement occurring. So like pushing into something sturdy. So like pushing a ball into a wall to strengthen the shoulder. Those are really good because the joint is in a stable position. So like elbow at your side in the case of the shoulder, and then you can strengthen it that way.
I like that. That's a really good little nugget of information. Now, would you say even like are wall sits helpful? Are planks helpful in that case as well?
Planks can be a little bit too hard. Usually I back off planks a little bit and use quadruped, which is like on all fours, so like hands and knees. And that's a really good kind of pre-plank position that's still anti-gravity. So they're working a lot of like their postural stabilizations without having to go like full on plank. Wall sits would be good for the knee. I like that because you're still strengthening the quad and stabilizing, but you still have the nice stable surface of the wall.
Okay, good to know. What is one thing that you wish that every hypermobile person knew about their body?
It doesn't have to be painful.
Mm.
You can figure out ways to strengthen and stabilize. Exercise is good. There was like an old adage that motion is lotion.
Hmm.
I don't know how much I agree with that exactly, but I do like it for this case because if you stop moving, it's only going to get worse. Like you might feel really good when you don't move for a day, but trust me when I say that if you do that every day, you're going to really lose a lot of that strength, and then all of the pain is going to get a lot worse.
And for someone with hypermobility who feels maybe discouraged or afraid to exercise, what advice would you give them about helping them to move safely?
Go see a PT or a personal trainer who knows EDS
Mm.
because it may be too much to do on your own, but you can use your resources to find help, and you can start slow and steady, and again slow and steady definitely wins the race in this case.
Absolutely. And I think too, something that I talk about a lot on here is even if someone like wanted to work with a personal trainer or even a physical therapist, it doesn't necessarily need to be forever. Like y- I would say physical therapists more than personal trainers. We all try to educate, right? We want to educate people on how they can have a sustainable, healthy life as they continue to go on. Now, maybe physical therapy is more necessary, like long term, but at least with personal training and strength training, I always say if maybe it's like a financial burden or maybe you just want to try something new, try a personal trainer for like a month, and then you can take what you learn from that personal trainer and try to adapt it and take it on your own if you feel comfortable with it. I'm also a huge proponent of personal trainers and physical therapists working in tandem and also like working with doctors. So if you are working with a personal trainer or if you're working with a physical therapist, finding someone who is going to kind of collaborate and be willing to work in tandem. Have you found a lot of maybe your clients who are working with personal trainers that you communicate with in that way?
I love collaboration between professions.
Mhm.
Absolutely. So I didn't know before today any hypermobility personal trainers, but I certainly have worked with personal trainers for other clients too, and a lot of athletic trainers too, especially in my concussion patients.
Mhm.
But I'm happy to start working with you.
I love it. I love it. So, Cheryl, the last part of my show here is called absolution. So, the fitness industry can be a little bit toxic sometimes, and we try to get rid of any guilt or shame around anything, maybe a topic that you are passionate about. So, what do you think? What is something that we can absolve ourselves of today in the hypermobility world?
I would say not all PT is created equal. And just because you tried PT before and it didn't work, you should try it again because, especially a hypermobility PT, will approach what you're going through very differently than maybe somebody who's just regular general orthopedics who might treat an occasional EDS patient or, oh, I know what it is. I had a hypermobile patient once. Definitely find yourself a hypermobility PT because most likely we can help you.
Amazing. I love that. Well, thank you so much, Dr. Cheryl, for your time today. You were a wealth of information as far as hypermobility and EDS goes. So thank you so much for your time. And I really appreciate you sharing your knowledge here with all of us. I know I learned something new. I hope you in the audience learned something new as well.
Thank you so much for having me, Abby. It was a pleasure to be here and to meet you. And I hope that our podcast today can help some people.
Absolutely. Thank you for listening to this episode of Talk Your Abs Off. I will see you on the next episode.